Good morning. My name is Bob Pyatt. I'm a private practice radiologist in a 10-person group in south central Pennsylvania. And we are grid green users, we are DIR users, we are ICE users, and we are a wannabe NMD user once we can get our mammography data so it can be easily put into the database. So hopefully a year from now we'll have that. But we're going to go to our next section and talk a little more about registries and the value for PQI. For those of you that are not familiar with PQI, that is a requirement for maintenance of certification for your board renewal for the younger and mid-aged radiologists. That's a big issue. So our next speaker is Tom Dykes from Hershey. Dr. Dykes is Chief of Abdominal Imaging at Hershey Medical Center up in Pennsylvania. Tom.
Good morning, and thank you for this opportunity. The IV contrast extravasation project is a multi-institutional project across the country, and it's also a project that demonstrates the application of PQI principles to this problem. The development of ICE, and this is not the immigration ICE, of course, this is the contrast extravasation ICE, is there were two societies, the Society of Abdominal Radiology, or the SAR, board of directors and subject matter experts that belong to the SAR, developed some reporting forms and ideas about contrast extravasation that we thought would be useful for radiology practices to report on and to use. So we developed first the contrast extravasation reporting form, which is a two-page form. As Dr. Chatfield described, this is a little bit user-intensive. You have to report on these data elements, but we thought all of these elements were potentially important in process improvement in this area. We also selected benchmarks for practices to compare their performance with each other. This, again, is a critical part of PQI. You have to compare how you do, compare with other groups, and identify areas that need improvement and then implement improvement steps. And part of that is we also, using the subject matter experts, developed educational materials for groups to use so that they could learn areas that they could improve in and have some suggestions for improvement. And I will say that the benchmarks that we selected initially came out of the literature because there are no benchmarks for this. And one purpose of this project was to develop benchmarks. So we used previous reports and literature to develop the benchmarks or to report the benchmarks. The American College of Radiology, led by Dr. Chatfield and Dr. Coombs, provided really unbelievable help in this because they developed the online website, and Mr. Meyer was critical in this development. They also developed online enrollment and data collection for the registry, the NRDR, which you've heard about already. The ACR also provides the feedback documents to each participating group or individual. A group can do this or an individual can do this project. And also provide a collection of the data and statistical analysis of the data, which is something that is greatly appreciated and needed. We had three major goals for ICE. First, to establish national benchmarks for three performance metrics rather than just using the literature. And the three benchmarks we selected was the contrast extravasation rate, or the number of events that happen per enhanced number of CT exams over a time period. The distribution of volumes of extravasation, we believe this is important because the general consensus is that a lower volume of extravasated material will result in a less severe injury. High volumes probably are associated with more severe injuries. And then lastly, this is the more difficult piece, is to assess severity of injury when an event occurs. The reason why this is difficult is that we followed a model used by the University of Michigan, where you call the patient at 2 weeks follow-up and see how they're doing. This gives time for the event to have resolved and to find out if there's any long-term effects. And so, as you can imagine, the job of calling the patient was my job. And some of them don't have active phone numbers. It was really quite a challenge sometimes to get in touch. But we actually, at Penn State, were able to get in touch with every patient that had an extravasation injury. But I will say that was, for me, the most difficult part of the project. The second goal was to assess the effectiveness of applying PQI principles to extravasation events, and I'll go into some of the data we collected on that. And again, this can be applied to either a single radiologist that wants to participate or a group of radiologists that want to participate. And the third goal was actually a tool that we thought would be helpful to get groups and people to participate. As Dr. Pyatt just said, PQI is a requirement from the American Board of Radiology. Every radiology graduate since 2003 has a time-limited certificate of 10 years. That means they have to take an exam, they have to have valid medical licensure, they have to do CME, but they also have to do a PQI project. Actually, they have to do 3 projects in that 10-year time frame. And so we designed this project to get pre-approval from the ABR that if you did the project and completed it, that would count as PQI. And so we thought that most radiologists would, because they don't have much knowledge of PQI, that would go, well, it's worth participating in because I can get my project done this way. Dr. Chatfield already showed a few of some of the data about the groups that participate. Now, at the time that I made this presentation, we were submitting a manuscript for a journal, and at that time we had 31 groups that have enrolled in ICE. I think the number now, Dr. Chatfield, is 50. And right now there are, I wrote down, I believe 26 that are submitting data. At the time when I did this, we had 15 groups that had completed the 2-cycle PQI project. And you can see the demographics of the groups. Again, very few academic facilities, and that's an area of recruitment for us to try to get more participation. Community practice was definitely the largest number, which is very good, and some freestanding clinics. You can see about a quarter of the practices are rural. Most are metropolitan or suburban groups, pretty evenly distributed across the country. And the last grouping was the number of contrast injections. This is a reflection of the busyness of the group. Again, a quarter of the groups that participated were fairly busy, 10,000 injections over a year. And just in a perspective as far as the risk of an extravasation or the rate, if you do 12,000 enhanced CT exams, you can expect about 1 event per week. So it's a little bit more common than what many people think. The results of this project, when we collected the first set of data, is we had 572 extravasation events out of about 240,000 enhanced CT exams. This is the largest reported data to date and will be in the literature. And also, this is a multi-institutional project, so all the other literature reports have been from single institutions, many of them large university practices. The extravasation rate for this project came out at 0.24%. In the literature, the range is 0.1 to 0.9%. So this falls within that range, and certainly sort of a little bit on the low side of that. So that's our rate. The range of extravasations for all groups was between 0.06 and 0.91%. The second metric, the volumes of extravasations, we had, of the events, 566 reported volumes. Of those, you can see that about 3/4 of them fell between 10 and 99 milliliters extravasated volume. Less than 6%, 0 to 9 mLs, and 12% greater than 100 mLs volume. This actually tracked very closely to what had already been reported in the literature from single institutions. Severity of injury. This is an important metric because the bottom line is it doesn't really matter outside of discomfort to the patient. If there's minimal injury and they all get better, it's like that's a good thing. So we had 440 events that reported severity of injury, and similar to, again, the literature review is that 95% of them are mild injuries. They have no sequelae of the extravasation after 2 weeks of follow-up. We did have 20 events that had moderate injuries, and out of all these extravasations, only 2 severe injuries, very low, and that tracks also with the data in the literature, or 0.05%. One patient did require a fasciotomy for compartment syndrome. Another patient didn't have surgery but had long-term disability of the extremity that had the extravasation. Since this is my part of this talk is on PQI, this addresses that, that aspect of it. So the first column is the first 6-month reporting period, and this is 15 groups. Not all the groups have completed the 2-cycle PQI project. So the extravasation rate for the first 6-month period before improvement methods are used to try to improve their practice was 0.27%, and that changed to 0.22%, a very modest change, but it is a downward shift that Dr. Chatfield had mentioned earlier. The estimated volumes extravasated, there really was not much change, perhaps more of a centralization of the volumes, after the second 6-month measurement period, after improvement had been implemented, about 85% fell into that 9 to 99 mLs extravasation, and before it was like 75%. And not much change in the higher volumes or 100 mLs or more. Severity of injury, the bottom rows, again, not much change. The mild injuries, of course, dominated at between 96%. There were, however, no severe injuries in the second reporting period. And again, this may be, they're so rare anyway, this may be just by chance. But anyway, at least we didn't have any severe injuries. Now, this is something that came out of the data that was a little bit unexpected to me, is that some practices use devices called extravasation detection accessories. These are devices, pads that you place on the skin over the IV site where the catheter is. It measures electrical impedance. Now, there's different types of these, but the ones that we use at Penn State uses electrical impedance. And when you extravasate, it changes the impedance in the soft tissues, and it shuts off the injector automatically. So the theory is it'll detect extravasations much more quickly than just looking at the injection site or feeling for swelling. And the red columns are all the events that did not have an EDA used, which were 517 events, and the blue were where an EDA was used. And there were only 50 events, so this is not a large number. But you can see there is a downward shift pushing to the left with lower extravasation volumes with the use of these accessories. Now, these have been around a long time. The literature for these accessories is actually not real current, and the articles that I had read were quoting that they can stop extravasations at 10 to 20 mLs every time with very few false positives. In other words, they stop the injection when there really isn't an extravasation. This data would suggest it does have a beneficial effect, but not to the level of less than 20 mLs. You can see there was one event, that far right column, that 2% number, where there was still greater than 100 mLs extravasated with an EDA used. So maybe they didn't plug it in, I don't know. But they're not perfect. The last thing is we tried to look at the data and find all these data elements that could be perhaps used to maybe predict which patients may be at more risk for moderate or severe injuries. We grouped those two together because the numbers were so small. And we collected a lot of data elements, and of all the elements, only 2 seem to be, have some statistical significance association with moderate or severe injuries. And the first one was extravasation volumes greater than 50 milliliters, which is what the data had reported in the literature previously. And the second was, interestingly, if a service other than radiology started the IV, they had a fairly significant higher risk of having a severe injury. Now, those would be IVs started in the emergency department, inpatients, out in the ambulance coming in. And that also had been reported in a couple of previous articles. So the way this data works, I don't have a pointer, I don't think, that I can use, but if you look at the total extravasations and drop down that column, you'll see not radiology, 286 events. So out of all the extravasations, 65% of them occurred in catheters placed by not the department, not radiology. Then if you slide across that row to the number 19, that actually resulted in 86% of moderate or severe injuries. So a disproportional number of moderate and severe injuries occurred with catheters that were not placed by radiology. And then the same reasoning is for the estimated volume extravasated. The bottom row is greater than 50 mLs. You can see that 38% of all the extravasations were in that range of volume, but it accounted for 77% of the moderate and severe injuries. So that's the type of analysis that Dr. Chatfield and the ACR has tried to help us sort of look at. And again, we collected a ton of data and only came up with these two as having statistical significance. In conclusion, this project is still open. It's one of the smaller registries. It does take some work on whoever's going to run it. It does not have to be a radiologist. It can be an administrator or a tech or a nurse. We are now using our own 3 benchmarks, not the literature benchmarks, to compare practices to. So we've already migrated to that stage. And we are constantly making modifications to the project and to the reporting forms based on problems that are reported to us. We have a committee made up of 5 members, and when we identify a problem, we usually by email, just email each other and talk about ways and suggestions to make changes, and basically by consensus, if we all agree, then we recommend the change, and then the ECR implements that change. Thank you very much.